So when you talk about the guidelines, I really like to think about it in 3 different ways. 95% of blood clots are preventable, so the guidelines really focus on how do you do prevention. There's also the diagnosis. There's recommendations for how you go about ordering an ultrasound or who qualifies to order an ultrasound. Not everybody should have one. And then step 3, what are the treatment guidelines? So these are the guidelines from 2016, and they really use the Caprini model. And we've all known that as you add points, your risk goes up. In 2011, 2012, the University of Michigan published a study and developed a super high risk group. And they found that not only after 5 points are you at risk, but at 7, 8 points, you're up to a 13% risk of a blood clot. And so that created a super group. And also, they determined that the length of treatment should be considered. So if somebody recovers from a hip surgery in 1 week, that's unique. But if they recover in 2 months, you should really consider the length of the prophylaxis really should match the recovery phase. So Dr. Caprini was kind enough to put this on venous and I really have trained our staff to do this when we have patients that have DVTs. We have our patients load this. We give them a copy of it. You can do online. There's an app for your phone. But basically what we do is, hey, you've had a blood clot. This is what you need to do to assess your risk going forward. And we try really hard to do a lot of education. This is a nice tool because as you add up your points, venous varicose veins is the 3rd item on there. So that brings that to the attention of our providers and referring docs as well. But also, if you click through the site, it will go and say what the current American College of Chest Physician recommendations are for prophylaxis. So whenever I give this talk, all the doctors are like, I have this patient with this. I just run them through the model. And the guidelines actually go through and talk about every single type of patient, cancer patients, cardiac, thoracic surgery. I've included it for interest's sake, just so you're aware that it is in there. So if you ever need, you have a specific question, you can just pull up the 1,000-page document and look it up. Spinal surgery, craniotomy, trauma, orthopedic surgery. And so the key parts here are extending the thromboprophylaxis. And so again, if you're doing a procedure like a gallbladder where they're going to be up and at them in 24 hours, probably can just do perioperative Lovenox if they're high risk. If you're not up and at them at the 2-week period, extend the prophylaxis. And again, critically ill patients, immobilized patients. So step 2 is how do you do the diagnosis? And patients just don't always get an ultrasound. In fact, the American College of Family Physicians, ER physicians, they all use a model, and it's usually the Wels model that they use. And this was a grade 2B recommendation in the guidelines as well. And if you look at the Wels model, I really don't like the Wels model because it pokes a lot of holes, and I think we miss a lot of disease. But basically, you look at some of the signs and symptoms, and then at the bottom, you'll notice that if they have another diagnosis that's just as likely, you can actually subtract points. But they have been able to correlate the number of points with a statistical risk. And based on your statistical risk, and these are all modifications, there's a 2-step for pulmonary embolus and a Geneva as well. But based on how many points you get in this model, there's a flowchart basically that correlates with it. And at low risk, you're supposed to do a D-dimer. If it's positive, then you do the ultrasound. If it's negative, you don't. Now, some people have argued that the D-dimer is causing us to do too many ultrasounds on people. And so there's some debate about that. There's a lot of new information that came out about that should be, if you've had surgery, your D-dimer is going to be elevated. So that maybe that's not the most sensitive indicator. So look for that in 2022. But if it's negative, you can stop. If you have a moderate risk, again, you can do the D-dimer. And if it's negative, you can stop. But if you have a high risk or high probability, then you really need the ultrasound. So the Wels model is also an app that's available on your phone. And again, those are endorsed by most of our primary docs out in the field. In step 3, the treatment. So really, this set of guidelines put VTE together. So it took pulmonary embolus and DVT that had kind of been thought of as 2 separate entities and combined them. And For an acute distal DVT, this was another topic that came up. In the past, if it wasn't up to the popliteal, everybody would say, you don't have to do anything. But 1/3 of all pulmonary embolus were assumed to come from below knee or below the popliteal clots. And so that recommendation has changed. So if they have no symptoms and it's a below knee clot, you can watch it, but it requires serial imaging. And serial imaging for us is a little difficult if the patient goes to the emergency room because we're seeing them 2 to 3 weeks after. And so that clot would have already progressed or embolized by that time. So in our clinic, if we're going to watch an EFIT or something like that, they're asymptomatic, then we're going to rescan them for that 2-week window to make sure that there's no propagation. If patients are symptomatic, though, the guidelines say you should treat them, just the same as you would treat a proximal. And they also divided, the guidelines divided cancer and non-cancer patients. And the reason for that is because with the factor Xa inhibitors, they became the front line of therapy for most clots, except for cancer patients. In cancer patients, Lovenox was preferred over Coumadin, and Coumadin was preferred over the factor Xa inhibitors. For non-cancer patients, though, the factor Xa inhibitors were the go-to. What's nice about that is that really allowed us to start treating these as an outpatient pretty consistently. The other division, or the way I think about clots, is provoked or unprovoked. You had a hip surgery, 60% of people will get a clot without prophylaxis. It's probably cause and effect. I drove to work, it took me 1 hour to get there, probably not a provoking factor. And so everybody gets treated for 3 months. But now if it's your first event and it's unprovoked, you should consider right out of the gates lifelong anticoagulation. Your second, provoked or unprovoked, doesn't matter. You're considering lifelong anticoagulation, which is interesting. I have hematologists in our area that actually take patients off anticoagulation because they'll say, you've been on Coumadin for 7 years, you haven't had a blood clot, let's stop the Coumadin. I'm like, it was working, and I see them back because I have a recurrent clot. So I try to do a lot of education, and this is a really nice way to be able to kind of justify and validate your recommendations. And clots with cancer, remember that 20 to 30% of the people that you see with a new clot are going to have a malignancy. And so with active cancer, they recommend extended anticoagulation over 3 months, at least if they're in the course of treatment or have indwelling catheters. Pulmonary embolus, again, you can manage this as an outpatient. Ken was speaking to the fact that you guys had done some research and found that these can be managed safely as an outpatient. The thrombolytic treatment really has to be limited to those who are hypotensive, shocky, or are on the verge of shocky. If they're a high bleeding risk, you really have to consider, is this patient going to die? If they're going to die, you need to do the lytic therapy. But you have to remember that pulmonary embolus kills more hospitalized patients than any other thing in our country. And so the Surgeon General really did a call to action and said this is the most preventable cause of death in our hospitalized patients. Upper extremity DVTs, there are 5 million indwelling catheters put in our country a year. 1/3 of indwelling catheters will get a clot. Those should be managed as a deep vein thrombosis. When I was a resident, our nutritionist was putting PICC lines in everybody. He ultrasounded them and found that 30% had a clot right there in the atrium, just right at the tip of that catheter. And so, again, our oncologists are saying, well, we're going to leave that catheter in there. We're going to treat them. But those people can go on to develop limb swelling from that indwelling catheter in that clot. Recurrent clot, if you have recurrent, if you have recurrent clots while on anticoagulation, first assume that there's some problem taking the medication or they're subtherapeutic. If they are clotting while on therapeutic doses and you're confident of that, you can switch them to Lovenox. If they're still clotting on that, you can increase the Lovenox dose by 1/3, provided their renal function's good. And in conclusion, I think it's our job to be educated about these guidelines. I think our patients need this. As we educate our patients, they educate their primary care docs, really makes you an expert in the field. And look forward to February's new guidelines. Thank you.
Thanks very much.